Hi, I'm Jeremy Abramson from the Mass General Hospital in Boston and Harvard Medical School. And it's my great pleasure to be here on Research to Practice today to talk about some of the lymphoma highlights from the big summer meetings that have occurred over the last several months. I'm going to start by thinking about abstracts that were presented for CLL. There were several long-term follow-up abstracts that I think are incredibly important. One here was ibrutinib versus placebo in patients with treatment-naive CLL. And these were final results of the phase 3 double-blind CLL12 trial. This study enrolled over 300 patients with asymptomatic CLL and was really asking the question of whether early ibrutinib versus observation might help improve outcomes in patients with CLL, where standard observation has long been our routine practice as opposed to early intervention. And what we can see from these data is that if you take patients randomly assigned to ibrutinib versus placebo, that the event-free survival is improved in patients receiving active therapy compared to patients on surveillance as expected, but no difference whatsoever in overall survival. And I think in the absence of early intervention showing an impact on overall survival, surveillance alone remains our standard of care for early stage asymptomatic patients. But importantly, prior studies have really evaluated historic comparators like chemotherapy. This study looked at a modern comparator of a BTK inhibitor, and based on this, surveillance alone remains standard of care for asymptomatic patients. Another study, in the absence of a randomized trial comparing acalabrutinib versus zanubrutinib, a matched-adjusted indirect comparison was performed comparing patient-level data from the ASCEND trial of acalabrutinib versus the ALPINE trial of zanubrutinib. Now, both acalabrutinib and zanubrutinib have been independently compared to ibrutinib in randomized trials of relapsed refractory CLL, but no direct comparator exists between these two second-generation BTK inhibitors. This matched adjusted indirect comparison found no difference in progression-free survival between acalabrutinib and zanubrutinib, though both were confirmed to look superior in terms of progression-free survival to ibrutinib, as shown here on this efficacy curve, with an improved 12-month progression-free survival for acalabrutinib and zanubrutinib, both at 91-92% compared to ibrutinib at 84%. In terms of toxicity, there were similar grades of toxicity overall, particularly grade 3 and higher, AFib, bleeding, and adverse events leading to treatment discontinuation. However, if you look at any grade hypertension or any grade bleeding, those risks were actually lower with acalabrutinib than zanubrutinib. But I think if you look at the safety profile on this particular forest plot, I would argue that it looks very similar between acalabrutinib and zanubrutinib. And I think these data suggest what we've previously anticipated, which is that the next generation BTK inhibitors, zanubrutinib and acalabrutinib, are preferential certainly in terms of toxicity compared to ibrutinib, and probably superior in terms of efficacy as well when using progression-free survival. So continuing our consideration of zanubrutinib in patients with CLL, the SEQUOIA study, this trial of treatment-naive CLL patients, randomized patients between zanubrutinib and BR if they were 17p deleted. And importantly, there was a separate cohort on the SEQUOIA trial for 17p deleted patients, all of whom got zanubrutinib treatment without randomization. This study was presented at EHA with extended follow-up, now at a median follow-up of 44 months, and continued to show a significant benefit for zanubrutinib over BR. In this particular study, at 42 months, 82% of zanubrutinib patients remained progression-free compared to 50% of patients on BR, amounting to a 70% reduction in risk of progression or death. When looking at the 17p deleted cohort, this was 110 patients with treatment-naive 17p deleted CLL, and the outcomes in this group were also quite excellent, with a 42-month progression-free survival approaching 80%. And so I think this suggests to us what we already knew, which is that BTK inhibitors should be one of the preferred treatment options for previously untreated CLL in patients with a 17p deletion or p53 mutation. And while there's no randomized data tells which BTK inhibitor is the best, the SEQUOIA trial tell us that in a p53 17p deleted patient, that durable remissions are seen with continuous dosing of zanubrutinib, here approaching 4 years. Extended follow-up for another study in previously untreated CLL comes from the landmark CLL14 trial, which established venetoclax obinutuzumab as an upfront standard of care option for previously untreated patients with CLL. A big difference between venetoclax obinutuzumab compared with BTK inhibitors as initial CLL therapy is that venetoclax obinutuzumab in this study was administered as 1 year of fixed duration therapy followed by observation, whereas the BTK inhibitors are dosed until progression or intolerance. This study was now presented with 6 years of follow-up data, and with 1 year of time-limited therapy, that means this study is presented with 5 years of patients having observation after completing treatment. And the median follow-up is now 76 months. Not surprisingly, the progression-free survival remains superior, and in fact, the median PFS for venetoclax obinutuzumab was 76 months compared to 36 months on chlorambucil obinutuzumab. And if we look at the 6-year progression-free survival rate, that means just over half of patients were progression-free at 6 years. Again, 5 years after completing venetoclax obinutuzumab, more than half of patients remain progression-free on that treatment, compared to only 22% on obinutuzumab chlorambucil. That amounted to only a third of patients on the ven obinutuzumab arm requiring next treatment, compared to nearly 2/3 of patients requiring retreatment on chlorambucil obinutuzumab. Now, this data is often applied primarily to 17p deleted, 17p wild type patients, whereas BTK inhibitors are often mentioned as preferred as continuous therapy for the 17p deleted or p53 mutated patients. But I did want to highlight here the subset data for the p53 mutated 17p deleted patients. And in those patients who received venetoclax obinutuzumab, the median progression-free survival was 52 months for patients on Ven-O. So while it wasn't quite as favorable, of course, as the 17p or p53 wild type patients, the progression-free survival was actually quite favorable. And at 52 months, it means a significant proportion of patients with that high-risk cytogenetic feature could have an extended treatment-free interval after treating with Ven-O. So while my personal preference is to use a continuous BTK inhibitor as initial therapy for a p53 mutated patient, for a patient who prefers time-limited therapy, or for a patient who has a bleeding diathesis or another reason why a BTK inhibitor might not be their first choice, I think venetoclax obinutuzumab is entirely appropriate therapy which can induce durable remissions. Extended follow-up for venetoclax is also seen in relapsed refractory patients on the MURANO trial. The MURANO trial compared venetoclax rituximab to bendamustine rituximab in previously treated relapsed refractory CLL. In this study, unlike the CLL14 study, patients received 2 years of venetoclax rituximab in this study. And with now 7 years of median follow-up, this benefit continues with a median progression-free survival of nearly 5 years, 55 months for venetoclax rituximab compared to 17 months for BR, amounting to a 75% reduction in risk of progression or death for patients receiving venetoclax and rituximab. If you look at the 7-year time point, it's remarkable to see that at 7 years, 23% of patients who got venetoclax rituximab remained progression-free, even 7 years later with relapsed refractory CLL, and that number was 0 with BR, and also with fewer patients who had venetoclax requiring an additional line of therapy. So I think these data continue to support venetoclax-based treatment as a relapse refractory option, certainly in lieu of BR, which I don't think has a major role in CLL anymore. This study also had 25 patients who'd received venetoclax rituximab and discontinued therapy per protocol after 2 years, subsequently progressed and then got retreated with venetoclax rituximab. And what they found is the response rate for those patients was 72%, and the median progression-free survival was nearly 2 years. And the median time that those patients had elapsed since their prior Ven-R was just over 2 years. So I think what these data tell us is if a patient receives venetoclax rituximab and they subsequently progress, that venetoclax rituximab remains an additional option for those patients, as would, of course, a BTK inhibitor if they were previously BTK inhibitor naive. So another question in previously untreated CLL is whether we could combine BTK inhibitors with venetoclax as opposed to choosing between the two. And that question is addressed in the phase 3 GLOW trial, which randomized treatment-naive CLL patients without p53 mutations or 17p deletions to the combination of ibrutinib and venetoclax or chlorambucil obinutuzumab, and this was time-limited therapy, which was updated at a median follow-up of approaching 4 years. Not surprisingly, the progression-free and overall survival continued to show improvement for ibrutinib and venetoclax over chlorambucil and obinutuzumab, and the forest plot showed that this was really superior in virtually all patient-specific and disease-specific subgroups, favoring venetoclax and ibrutinib over a historic option of chlorambucil obinutuzumab. Interestingly, a subset analysis within the ibrutinib venetoclax treated patients showed that patients with trisomy 12 or unmutated IGHV status had a shorter progression-free survival than other subgroups. Again, this did not include 17p deleted patients, but even in those subsets, it was superior to chlorambucil obinutuzumab. So based on these data, ibrutinib and venetoclax is certainly an acceptable option. I personally don't give ibrutinib venetoclax because I prefer next generation BTK inhibitors. So in my practice, I'm typically choosing between a BTK inhibitor such as zanubrutinib or acalabrutinib versus venetoclax obinutuzumab. But I think for a patient who really had a reason to avoid intravenous infusions and therefore did not want any obinutuzumab, then the all-oral combination of ibrutinib and venetoclax is an option based on this randomized trial. I think some really exciting data in the management of CLL is the evidence of lisocabtagene maraleucel in patients with relapsed refractory CLL. In a patient population of 117 relapsed refractory CLL patients, the TRANSCEND CLL trial treated these patients with lisocabtagene, one of two dose levels, dose level 1 and dose level 2. This was a high-risk population. The median prior therapies was 5. The median age was 65. And the majority of these patients had high-risk cytogenetic features, including complex karyotype, 17p deletion, p53 mutation, or unmutated IGHV. 88% of these patients were refractory to a BTK inhibitor. 100% of them had previously been exposed to a BTK inhibitor. And 53 of 117 patients had previously progressed despite previous exposure to both the BTK inhibitor and venetoclax. Using conventional IWCLL criteria, the overall and complete response rates were 47 and 18% respectively, though I think it's important to note that the IWCLL response criteria likely underestimate response because any slightly enlarged lymph node or spleen is captured as an incomplete response. So I think if you want a better idea of the biologic activity of the disease, you can look at minimal residual disease or MRD. And in fact, if you look at 87 evaluable patients, 65% were undetectable in the peripheral blood and 59% were undetectable in the bone marrow. That to me suggests a very deep activity for lisocabtagene in patients with multiply pretreated relapsed refractory CLL. And importantly, the response rate and undetectable MRD rates were really quite similar in the BTK venetoclax exposed population as the entire population, again highlighting that unmet medical need patient population who might really benefit from a treatment like a CAR T cell like lisocabtagene. And if we look at the progression-free survival based either on MRD status or on response status, we can see that the median progression-free survival for the entire population was 1 year in this study. And among patients with undetectable MRD, those really could be quite durable, as shown on the left-hand panel. And not surprisingly, patients in a CR did better than patients in less than a CR. These data show compelling evidence that CAR T cells can provide encouraging efficacy with deep remissions that can be durable in patients with heavily pretreated CLL despite prior BTK inhibitors and venetoclax. Now, toxicities of CRS and neurotoxicity do occur. And as shown here, the incidence of CRS and neurotoxicity were higher in this study compared to lisocabtagene studies in lymphoma, meaning follicular lymphoma or diffuse large B-cell lymphoma. I think that represents the tumor burden. CLL patients have a lot of circulating disease. They have a lot of disease in their bone marrow. And I think that is why there's a lot more T cell activation and CRS and neurotox. Importantly, most of that is low grade and really quite reversible, but often patients will need the use of tocilizumab and or corticosteroids. So, speaking of the BRUIN trial, there's that beautiful waterfall plot showing really a remarkable reduction in tumor burden in patients receiving pirtobrutinib after previously having received a covalent BTK inhibitor, which was most commonly ibrutinib. At baseline, what this study showed is the most common mutations and aberrancies were BTK mutations, not surprisingly, followed by TP53 mutations and other sort of common recurring mutations in CLL, including ATM, Notch1, SF3B1, and PLC gamma 2. Now, BTK and PCL gamma 2 mutations are the most common mutations we associate with ibrutinib resistance and resistance to other covalent BTK inhibitors, and that's most commonly the C481S mutation. So these investigators also looked at patients who were progressing on pirtobrutinib and looked at what happened to their mutational clones. And what they found was that the C481 BTK mutations largely cleared on pirtobrutinib, but that there was development of non-C481 BTK mutations, usually gatekeeper mutations, that likely impacted their resistance to pirtobrutinib. And most of these mutations were present at very low levels prior to pirtobrutinib therapy and then expanded while the C481 clones were eradicated. Importantly, the baseline mutational burdens did not appear to preclude efficacy of pirtobrutinib, again showing that pirtobrutinib is our best option today as far as an approved commercially available treatment option for relapsed CLL patients who've had a covalent BTK inhibitor, particularly who've had a BTK inhibitor plus venetoclax. Turning our attention to follicular lymphoma, we also have some exciting follicular lymphoma data, including CAR T cell data. These are data from the CIBMTR registry, which included 230 patients from 72 participating centers in the United States. And these were looking at patients who received axicabtagene for relapsed refractory follicular lymphoma, in line with the FDA label, where axicabtagene is available for third-line and later treatment for follicular lymphoma. Among 151 patients evaluated in this registry who received axicabtagene, you can see these were heavily pretreated patients with a median of 4 prior lines of therapy. Axicabtagene in the real-world setting was really extremely effective, with 148 response evaluable patients. The overall and complete response rate were 93 and 84% respectively. And you can see that the duration of response, progression-free, and overall survival medians have not been reached, though at a very brief median follow-up with the progression-free survival limit here measured primarily in patients being followed for 9 months or less. That said, early evidence of durability with longer-term follow-up required, but very high rates of complete remission in heavily pretreated patients with follicular lymphoma. Axicabtagene, of course, does have the highest rate of CRS and neurotoxicity among the approved products, CAR T-cell products for follicular lymphoma. And here, indeed, the majority of patients developed CRS at 73%, but was severe in only 2%. ICANS developed in 39%, so not a majority. That's lower than we see in diffuse large B-cell lymphoma, and was severe in 12%, and this is usually manageable and reversible. So I think axicabtagene, this validates the prospective ZUMA-5 data that showed high rates of complete response and durability in patients with relapsed refractory follicular lymphoma. The question, of course, is where this fits with bispecific antibodies, and I'm going to show you updated data for bispecific antibodies as well. Now, the TRANSCEND follicular lymphoma trial of lisocabtagene maraleucel just presented the pivotal data from the TRANSCEND follicular lymphoma trial at the ICML meeting in June. This is the first report of this pivotal study looking at liso-cel as a third-line or later treatment in patients with relapsed refractory follicular lymphoma. 107 patients were in the primary efficacy analysis, and you can see that the median age was 62. The median prior lines of therapy was 3. The majority of patients had a high-risk FLIPI score. The majority were refractory to their immediate prior line of chemotherapy, and the majority had POD 24. So this was a high-risk group. The response rates are really quite remarkable. You can see the overall and complete response rates were 97 and 94%, a 94% CR rate in heavily pretreated follicular lymphoma, which is the highest CR rate reported to date for CAR T cells in relapsed follicular lymphoma. The toxicity profile was overall favorable. As expected with liso-cel, CRS and neurotoxicity occurred in 58 and 15% of patients respectively, but this was almost entirely low grade, with only 1 and 2% of patients having grade 3 CRS or ICANS respectively. There were no grade 4 or 5 CRS or ICANS events. Longer-term follow-up, of course, is required, but at 1 year, we see that the median duration of response and progression-free survival have not been reached at the time of this analysis. And remarkably, at 1 year of follow-up, 81% of these patients remain progression-free. 82% of responders remain in response at 1 year of follow-up. So I think these data show deep responses with ongoing follow-up to assess durability needed. But these are, I think, encouraging data for an additional CAR T-cell in relapsed follicular lymphoma, and one with a lower incidence of severe CRS and neurotoxicity than axicabtagene. Now, what about bispecific antibodies? These are, of course, the other major player now. Mosunetuzumab, administered intravenously, is FDA approved as a relapsed refractory follicular lymphoma treatment in patients who'd received 2 or more prior therapies. And that's based on this pivotal trial with the updated data presented at EHA. Remember, mosunetuzumab is administered by step-up dosing over cycle 1, and then once per cycle in 21-day cycles. Patients who achieve a complete response at 8 cycles discontinue therapy. Patients in less than a CR can receive up to 17 total cycles of treatment. In fact, the majority of patients, 59%, did receive 8 total cycles of treatment, meaning they achieved a CR and discontinued, while only 12% of patients finished a total of 17 cycles. These data show that with ongoing follow-up that these responses can indeed be encouragingly durable. What was particularly reported were the outcomes based on when patients achieved a complete response. The majority of patients who achieved a complete response early, meaning within the first 8 cycles and stopped at 8 cycles. 21 achieved a late CR. And what we can see in these data is that the median duration of response was not reached for any CR patient, whether or not they received an early or a late CR. But if a patient had a PR as their best response, the median duration of response was only 4 months. So it really is important, it appears, to achieve a CR. Furthermore, if we look at the duration of CR now with 2 years follow-up, the median duration of complete response was 65%. So 2/3 of CR patients remaining in response at 2 years, and the progression-free survival for those CR patients was 77%. So I think these data show us that these responses with time-limited therapy in relapsed follicular lymphoma can be durable among the patients who achieve a CR. I'll remind you that the complete response rate on this study was 60%, 6-0. So the majority of patients achieve a CR, and among those patients, 2/3 will remain in response at 2 years. So I think in practice, we have to consider whether we take that third line and later patient to a bispecific antibody, an off-the-shelf option like mosunetuzumab, and give them up to 8 cycles or as many as 17 cycles based on response, or a more one-time treatment like CAR T cells with either tisocel, axicabtagene, or potentially lisocabtagene based on the TRANSCEND data I've just shown you. And in my general practice, I am favoring bispecific antibodies as a third line option in most patients. It is a bit easier. It is off the shelf. I will say that in my very high risk patients, particularly those POD24 patients who receive initial chemoimmunotherapy, progress within 2 years, then get a second line therapy such as lenalidomide, rituximab, and progress after that, I'm favoring CAR T cells in that high risk POD patient. Most other patients, I'll typically go to a bispecific antibody where I think the results look quite good and reserve CAR T cells as a treatment in patients who progress despite a bispecific antibody. So speaking of bispecific antibodies, here's an appealing combination option looking at adding epcoritamab to lenalidomide rituximab in patients with relapsed refractory follicular lymphoma. And these high-risk features, which was most notably having POD24, having primary refractory disease, having high FLIPI risk disease, or having disease that was double refractory to CD20 antibodies and alkylating agents. When these high-risk patients were treated with this triple combination, you can see that the overall and complete response rate were quite excellent at 98 and 87% respectively. This is not a randomized trial. This is a phase 2 trial, so it's hard to know what epcoritamab alone would have done in this particular patient population, but I think this is a very high complete response rate. And importantly, when they looked at POD24 versus non-POD24, the success rates were really quite similar based on POD24 status. So I think this is a very appealing potential regimen for high-risk patients, particularly high-risk POD24 patients who you might otherwise be thinking about a CAR T-cell treatment. Or as an option for adding epcoritamab in second-line management as opposed to waiting for third-line. And you can see the median prior lines of therapy in this study was 1, suggesting that many of these patients were indeed receiving epcoritamab R-squared as a second-line treatment, where I would otherwise be giving R-squared alone. The toxicity profile was really as expected for these drugs. There were some cytopenias related primarily to the lenalidomide rituximab. The CRS occurred as predicted, predominantly on on day 15 of cycle 1. Where the incidence approached 40%, but there was only a single case of grade 3 CRS, with all other cases being low grade. And the progression-free survival, mind you, at a very short interval follow-up, looked generally quite good, with the overall population, 78% of patients remaining progression-free if they had POD24, and among the entire population, 85% of patients were progression-free at 9 months. Another bispecific antibody I alluded to was odronextamab. Odronextamab has been studied in the multi-arm ELM-2 trial. And in the follicular lymphoma arm of the ELM-2 trial, grade 1 to 3A relapsed refractory follicular lymphoma patients were included as long as they'd received at least 2 or more prior lines of therapy. 131 patients were enrolled, meeting of 3 prior lines of therapy, and also plenty of high-risk patients. 59% were FLIPI high risk, 71% refractory to their immediate prior line of therapy, and nearly half of patients had POD24. Again, high response rates was an overall response rate of 82%, with 3/4 of patients having a CR. There's a bit potentially more CRS seen here, with any grade CRS occurring in 57% of patients, but this was almost entirely low grade, with only 2% being grade 3 or higher, and really very rare incidence of ICANS. The median progression-free survival was 20 months. The median duration of complete response was 20.5 months. So I think these data show that odronextamab, like mosunetuzumab, has shown encouraging response and durability, and longer-term follow-up is really going to be needed to assess ultimate durability of response. I'll also note that the dosing of odronextamab is a bit more inconvenient than some of the other bispecific antibodies. To mitigate the risk of CRS, the dose is split over 2 days over the first 3 weeks of treatment, and requires hospitalization over those 2 days. Treatment is then given weekly for 3 months before being spaced out to every other week and ultimately monthly. But the twice weekly administrations during the dose ramp up period, along with hospitalizations, is a limiting factor convenience-wise, because it's more so than the other products, and warrants ongoing investigation to try and decrease the cumbersome nature of that dose ramp-up period, particularly in lower-risk patients. Then there's a newer bispecific antibody, TNB-486. This has an activating anti-CD3 domain and a CD19 binding, as opposed to the other bispecifics I've highlighted, which all target CD20 on the surface of B-cell lymphomas. So this is a CD19 bispecific antibody. We have very minimal data from this phase 1 dose escalation trial. This drug is given intravenously, and it's given in 2-week intervals for continuous dosing. For patients enrolled on this phase 1 study, I would note that the incidence of CRS and neurotoxicity was fairly high. 2/3 of patients had any grade CRS, and 1/4 of patients had ICANS, which is much higher than we see with the other bispecific antibodies in relapsed follicular lymphoma. There was no high-grade CRS, but 6% of patients had high-grade ICANS. And so whether this is due to the CD19 targeting or other elements related to this construct is unknown. But I think this does warrant ongoing attention. Again, only 17 patients evaluable for toxicity, so the full story is probably not yet told. If we look among all patients, though, the responses look good. 91% of 11 evaluable patients have responded, including the majority of patients with high-risk features, and many of those responses are ongoing at last follow-up. So I think these are encouraging data in a very small number of patients. It targets a different antigen than the other bispecific antibodies, but I think we need to dive deeper and see whether this higher rate of ICANS and CRS is true, or whether that is perhaps a selection bias function early in the trial. Turning our attention to a lot of exciting advances in mantle cell lymphoma, I think right now we typically use chemoimmunotherapy as our initial treatment of choice for patients with mantle cell lymphoma. But a relevant question, particularly in older adults, non-transplant eligible patients, where we typically use bendamustine rituximab as our treatment of choice, can we dispense with chemotherapy entirely and use acalabrutinib rituximab in a chemotherapy-sparing strategy? Otherwise, of course, BTK inhibitors, including acalabrutinib, are approved in the relapsed refractory setting and are my typical go-to option as second-line treatment. But this investigator-initiated trial evaluated 50 patients with treatment-naive mantle cell lymphoma, giving acalabrutinib as their initial treatment. Acalabrutinib was given continuously at 100 milligrams twice daily per routine. Rituximab was given weekly for the first month, then monthly for 1 year, followed by every other month in a maintenance program to complete 2 total years of treatment. Among these 50 patients, these were older patients with a median age of 69. I wouldn't say these were particularly highest risk patients. Most had classic morphology mantle cell lymphoma. Only 22% were MIPI high risk, but 28% did have a p53 aberration, including 17 deletions or p53 mutations. If we look at the response rates, they were really quite remarkable. The overall and complete response rates were 94 and 90% respectively. Those CR rates are higher than we expect for acalabrutinib alone, for example, in relapsed mantle cell lymphoma. And though the median follow-up is short, you can see at 12 to 15 months, the vast majority of these patients remain progression-free, with only 3 of these 50 patients having progressed at last follow-up. So I think these are exciting data. These are exciting chemotherapy-sparing data. I think the follow-up is too short to really make this a standard of care, but I think it is enough to say we should investigate this further and potentially think forward to a randomized trial where we evaluate a BTK inhibitor-based approach compared to typical chemoimmunotherapy with BR. What about pirtobrutinib? Pirtobrutinib is approved for patients with mantle cell lymphoma who've relapsed despite a covalent BTK inhibitor. That's based on the mantle cell lymphoma cohort of the BRUIN trial, which we reviewed earlier in CLL. These updated follow-up now with greater than 3 years of follow-up for these patients shows that in 90 patients who'd previously received a covalent BTK inhibitor, the overall response rate was 57% and 19% of patients having a CR. So again, most of these patients are indeed partial responders with only a small proportion achieving a CR after prior BTK inhibition. The median progression-free survival was reached at 7 months with a median follow-up of 14 months. And among the responders, the median duration of response was about a year and a half. So looking at that Kaplan-Meier curve, I'd say that the progression-free survival and duration of response curves do continue to trend downward. To me, these data don't look quite as good as a CAR T cell, such as brexacabtagene autoleucel, which is approved for third line and later mantle cell lymphoma, and today would be my treatment of choice for a third line patient who's relapsing after a covalent BTK inhibitor. But I think these data tell me that pirtobrutinib would certainly be my treatment of choice in a patient who's relapsing or progressing after a CAR T cell treatment, or as a bridging therapy leading into CAR T cell treatment while the CAR T cells are being manufactured. These are the pivotal results from the TRANSCEND NHL mantle cell lymphoma cohort. This is using lisocabtagene maraleucel or liso-cel in relapsed refractory mantle cell lymphoma patients who'd previously received BTK inhibition. These were 83 patients with a median of 3 prior lines of therapy. You can see more than half of these patients were refractory to a BTK inhibitor. 69% were refractory to their prior line of therapy. The vast majority had an increased Ki67, and a third had blastoid morphology, and close to a quarter had a p53 mutation. The responses in the study to liso-cel were quite excellent, with an overall and complete response rate of 83 and 72%, respectively. With a median follow-up of 2 years, these responses do appear encouragingly durable. You can see that the progression-free survival rate at 1 year is estimated to be 53%, so a median that had not been reached at 1 year. And a median for the entire population that has been reached at 15 months. For those patients who achieved a complete response, which was the majority of patients, 60% of those patients remained progression-free at 1 year, 49% remained progression-free at 18 months. The waterfall plot shown there shows the vast majority, all but 3 patients, had a reduction in their measurable tumor burden. And the incidence of CRS and neurotoxicity was 61 and 31% respectively, but the incidence of severe CRS was quite low at 1%, and the severe neurotoxicity rate was 9%. Similar to CLL, liso-cel did appear to produce higher rates of CRS and ICANS in mantle cell lymphoma compared to diffuse large B-cell lymphoma and follicular lymphoma. And I think this, probably similar to CLL, represents the higher rate of bone marrow and peripheral blood involvement in mantle cell lymphoma patients compared to DLBCL and follicular lymphoma. And importantly, the rates of severe CRS and neurotoxicity compare favorably with brexacel, which is the other FDA-approved CAR T cell currently in mantle cell lymphoma. These data have not yet led to FDA approval, but my understanding is they will be submitted for regulatory consideration. And turning our attention to the most common lymphoma, diffuse large B-cell lymphoma, we have some other encouraging long-term follow-up data with ciloleucel, which is an anti-CD19 antibody drug conjugate. This is an FDA-approved drug in third-line or later diffuse large B-cell lymphoma based on this pivotal LOTUS-2 trial, which looked at 145 heavily pretreated patients with a median of 3 prior lines of therapy. 10% of these patients had double-hit lymphoma. The majority were chemotherapy refractory, and 10% had even received a prior CAR T-cell product. As initially reported, the overall and complete response rates were quite good at 48 and 25% respectively. And now with a longer-term follow-up, we can look at the progression-free survival. And if we look at all patients, at 2 years, a quarter of patients remain progression-free, which I think is pretty remarkable for a time-limited therapy that's given over 1 year with this antibody drug conjugate. Perhaps most striking is look at the complete responders. Again, this is 25% of patients, so it's not the majority of patients. But among those 25% of patients, nearly 3/4 remain progression-free at 1 year, with a duration of response of 72% as well at that time point. And among all patients, the 2-year duration of response was 45%. So I think loncastuximab tesirine with ongoing follow-up shows us that this is a highly effective option. I think DLBCL is a crowded space today. And typically, if I'm thinking about CAR T cells as my customary second-line treatment for my primary refractory and early relapse DLBCLs, I'm thinking about bispecific antibodies, either glofitamab or epcoritamab, as a third-line treatment. And I'm thinking about loncastuximab tesirine as effectively their fourth-line treatment of choice. I do know that the upfront studies are on hold. There are studies in the relapse refractory setting in combination. There are toxicities associated with it. There are LFT abnormalities. There's also an edema that occurs, sort of almost a capillary leak type edema that requires concurrent dexamethasone. And unlike most other medicines, in fact, I think the only medicine in lymphoma, there's a dexamethasone dose that's given for 3 days starting the day before the loncastuximab dose. So, my solid tumor colleagues do this with docetaxel all the time, but that isn't something we do with other agents in lymphoma. With the dexamethasone peri-dosing, that does decrease the edema, but there are toxicities associated with it. But I'm typically using it really post-CAR, post-bispecific antibody, where we can see encouraging responses in those patients. We also saw a slight update from the TRANSFORM trial. This was the second-line pivotal trial for lisocabtagene maraleucel compared to standard of care as second-line therapy in patients with primary refractory or early relapse diffuse large B-cell lymphoma. Now, in this study, 3/4 of patients had primary refractory disease, while the remaining 1/4 had disease that had relapsed between 3 months and 12 months after initial chemoimmunotherapy. And what this subset analysis did is break down the primary refractory patients on the top row and the relapse patients on the bottom row. What this shows is that lisocabtagene was clearly superior to standard of care, whether patients had either refractory or relapse disease. It also shows that among the patients with primary refractory disease, there's certainly an encouraging rate of durable remission with an ongoing event-free survival, shown here with a median event-free survival of nearly a year and a half among the lisocabtagene-treated patients, but that it doesn't look quite as good as the patient who had relapse disease. And the relapse patients, you can see the median, the event-free survival has not been reached. So I think what that tells us is having primary refractory disease is still a high-risk feature, but that those patients can clearly still derive durable benefit in terms of event-free survival and progression-free survival with lisocabtagene. But that patients who initially achieve a response and subsequently relapse, when those patients get treated with second-line lisocabtagene, their duration of response is even higher. Here with a typical progression-free survival that looks to be approaching 80% 2 years out. Then the major update in terms of updated analysis of the phase 3 trials in second-line large cell lymphoma was for the ZUMA-7 trial, which also compared CAR T cells, in this setting axicabtagene, compared to standard of care, again, second-line DLBCL patients who had primary refractory disease or relapsed disease within 1 year of chemoimmunotherapy. This study previously reported a progression-free and event-free survival benefit that led to FDA approval for this patient population, but with an overall survival that had not yet reached statistical significance. Now, with extended follow-up, what we can see is that the progression-free survival continues to show a clear benefit for axicabtagene over standard of care, with a 4-year progression-free survival of 42% compared to 24%. But look at the overall survival analysis now with a median follow-up of nearly 4 years. What you can see is that the overall survival is now significantly in favor of axicabtagene over standard of care, with a median overall survival not reached for axicabtagene patients and reached at 31 months for the standard of care patients. And this amounts to about a 27% reduction in risk of death favoring axicabtagene. So clearly, I think this further supports axicabtagene as a second-line treatment for primary refractory or early relapsed diffuse large B-cell lymphoma or other high-grade B-cell lymphomas. We can then see some ongoing follow-up from the pivotal studies of the bispecific antibodies in large B-cell lymphomas. This is the EPCOR-1 study of subcutaneous epcoritamab in relapsed refractory diffuse large B-cell lymphoma. This study accrued patients with 2 or more prior lines of therapy for diffuse large B-cell lymphoma, high-grade B-cell lymphoma, primary mediastinal B-cell lymphoma, or grade 3B follicular lymphoma. Patients received step-up dosing over cycle 1. They then received weekly dosing out for 3 months, followed by every other week dosing out to 10 months, after which patients were given treatment monthly. This is treatment until progression or intolerance. This is not a time-limited therapy. With extended follow-up among 157 patients, these are heavily pretreated with a median of 3 prior lines of therapy, including 39% of patients who'd received prior CAR T cells. The overall response rate was 63%, with 39% of patients achieving a complete response. With extended follow-up, we can see fairly encouraging durability. The median duration of response was 15 months for all responders, and among those 39% of patients who'd achieved a complete remission, their median duration of complete response was 21 months, and the median duration of complete response curves are shown there by the Kaplan-Meier method. CRS occurred in just about half of patients, but was severe in only 3%, and ICANS was not observed on this particular study. The timing of CRS was predictable, with the most patients who experienced CRS had it on cycle 1, day 15 of their epcoritamab ramp-up. We also saw long-term follow-up of glofitamab, the other bispecific antibody that's approved for relapsed refractory diffuse large B-cell lymphoma as a third-line or later treatment. Unlike epcoritamab, glofitamab is administered intravenously instead of subcutaneously. And importantly, it's also administered as time-limited therapy. So patients get weekly dose ramp-up over the first 21-day cycle and then get 1 IV glofitamab dose per 21-day cycle for a total duration of 12 cycles, after which treatment is discontinued in all patients. Additionally, patients get a pre-treatment dose of obinutuzumab to try and minimize the incidence of cytokine release syndrome. With extended follow-up, we see, again, high-risk patients, 155 patients, also with a median of 3 prior lines of therapy, and a third of patients having progressed after a prior CAR T cell. Overall response rate of 52%, 40% of patients achieving a CR. This analysis reported the ongoing duration of complete response rate, which has been reached with a median duration of complete response at 27 months, more than 2 years. And remember, these patients received 12 cycles of therapy at 21-day cycles. So the majority of these patients are remaining in CR despite being off treatment now for close to a year. You can see in the duration of complete response curve at 18 months, the duration of complete response is 67%. The progression-free survival is also looking encouraging, with a PFS rate of 18 months of 72% for responding patients. The CRS rate is a bit higher at 64%, but mostly low grade, with 4% of patients having grade 3 or higher CRS. And this fairly predictably happens after the first dose of glofitamab. And ICANS is typically not observed or only rarely observed with this product. So I think both of these studies show encouraging ongoing durability. It's particularly appealing that glofitamab is time-limited therapy with ongoing complete responders, the majority of these complete responders remaining in remission at last follow-up. Are these patients cured? I don't know that, but the follow-up is ongoing, and a lot of these patients have been in remission now for quite some time. So with ongoing follow-up, I think we may determine that, in fact, a subset of these patients may indeed be cured with time-limited bispecific antibody treatment. Odronextamab is not yet FDA approved, but is also being studied again in the ELM-2 trial in the diffuse large B-cell lymphoma cohort. These 140 patients have been updated at the recent EHA meeting. These were patients with a median of 2 prior lines of therapy, and 86% were chemotherapy refractory. Close to a quarter of patients had prior CAR T cells. The overall and complete response rates may be a slight bit lower than the other published CAR T cell products at 49 and 31% of patients respectively. The median duration of response was 10 months, and the median duration of complete response was 18 months. Again, this is a bit shorter than reported with epcoritamab and glofitamab, though these are non-comparative studies, and that could reflect patient selection more than efficacy of the product. But you can see at a year and a half, the majority of patients have progressed, with 26% of patients remaining progression-free at 18 months. But the duration of response can be durable among responding patients. And then finally, I think there was some big practice-changing data in Hodgkin lymphoma that were presented at the ASCO meeting and also in an encore presentation at the ICML. This was the SWOG-led intergroup trial, and this study used the standard comparator arm of brentuximab AVD, which is the comparator based on the prior ECHELON-1 study, which showed superiority of brentuximab AVD over ABVD. And in this study, randomized patients to either brentuximab AVD or nivolumab AVD, asking the question of whether it's better to combine an immune checkpoint inhibitor as opposed to brentuximab vedotin as initial treatment for advanced stage Hodgkin lymphoma. Patients were randomized 1-to-1 to nivo AVD or brentuximab AVD for 6 cycles. Importantly, G-CSF support was required on the BV-AVD arm due to the incidence of cytopenias with that regimen, whereas it was optional in the nivo AVD arm. These arms were well balanced based on high-risk features. The majority of these patients did have stage 4 disease and had the presence of B symptoms, and a third of patients had an IPS score of 4 to 7, meaning high-risk IPS. The primary endpoint was progression-free survival, and you can see at 1 year, the nivo AVD arm had a superior progression-free survival of 94% compared to 86% on the brentuximab AVD arm. This reflects a 52% reduction in risk of progression or death favoring nivo AVD. There was no difference in overall survival on this study, but I think it's important to note that on the forest plot that virtually all subsets of patients favored nivo AVD as opposed to brentuximab AVD, and that included older patients who seemed to garner less benefit from the brentuximab AVD regimen in the ECHELON-1 trial. The benefit was seen in the highest IPS score as well as the lower IPS score patients, B symptoms or not, and regardless of stage 3 or stage 4 disease. Now, with a robust PFS benefit, one has to ask, since there is no overall survival benefit, is there a difference in the toxicity profile? There are differences in toxicity, but overall, I would say the toxicity favors Nivo AVD over brentuximab AVD. What you can see is that neutropenia was more common in the Nivo AVD arm compared to brentuximab AVD, but that's because the brentuximab AVD arm required growth factor support, whereas the Nivo AVD arm did not require growth factor support, and it was used in only about half of patients. Similarly, reflecting that, bone pain was more common with brentuximab due to growth factor stimulation. But what was better about Nivo AVD? You can see less LFT elevations and less peripheral sensory neuropathy was seen. Brentuximab AVD also had higher rates of weight loss, higher rates of dyspnea, higher rates of rash, higher rates of abdominal pain, higher rates of anorexia, and higher rates of diarrhea. So I'd say overall, Nivo AVD was very well tolerated, was overall better tolerated than brentuximab AVD. There was no increased risk of infections in Nivo AVD, and there was not a high rate of neutropenic fever. And those, I think, are the excitement across multiple histologies, including CLL, follicular lymphoma, diffuse large B-cell lymphoma, mantle cell lymphoma, and Hodgkin lymphoma.